Okay, take two. So, welcome to today's live. We thought we were just live, but I forgot to press go live. So, thank you so much for joining us. Nurse Scott is here today, Nurse Adrian. I thoroughly enjoy having them on. They add so much to these discussions and they have so much wisdom that they can add to help you become a better nurse and also how to advocate for yourself if you are a patient in a hospital. We'll start with Nurse Scott. If you could introduce yourself.
Hey everybody, I'm Nurse Scott, and I have been a nurse for a long time. I started in 1992. Been working in the emergency department that whole time up until about 6 years ago when I went down with a bad back. So instead of just staying on disability the rest of my life, I decided to go back to grad school and get a master's degree and be a family nurse practitioner. And my channel is kind of my vlog where I take you through the ups and downs, and there have been a lot of ups and downs. So you can go on over there and check that out. I appreciate any support you can give me. And I'm really glad to be here too. It's glad to see you guys. It's like getting the band back together again after all these months.
Yes, and that's what we miss when we don't go live. Like I know live it's more nerve-wracking and we have to sometimes things come out of our mouths that we don't necessarily, I could have said that better. But it is nice to interact with other professionals and other friends in the same career. Adrian?
Hey, yeah, absolutely. I missed you guys and missed going live. I think I'm coming up on my near 1 year anniversary from when I joined the live crew. So yeah, welcome everybody to our live. And my name's Nurse Adrian Carrier. I have recently started a podcast, Being the Space. It's a playlist on my channel that you can pop into. And I'll be loading up a lot of episodes on that. Very excited. I've done quite a few interviews, and I'm also a nurse, RN. I'm a board certified patient advocate. I run my own company. I run a private patient advocacy business, tgpatientadvocates.com. And thanks so much. And just, hey, hit the subscribe button on all of us, follow, share these videos, and do all the things. Leave us nice, friendly comments and have good questions. We invite questions always.
Yes. And today we will be talking about a fatal medication error that did occur and it resulted in the death of a patient by a nurse. It's a medication mix-up blamed for death of a patient at Lexington Hospital. So we'll read the article first, and then we'll get more into how can you prevent this as a nurse, and also what can you do as a patient to protect yourself while you're in the hospital. So last summer, an 81-year-old man was transferred to the St. Joseph Health Main in Lexington. Within 48 hours, he was dead. The man was sent to Lexington Hospital because of a gastrointestinal bleed requiring a higher level of care, but it was a medication mix-up that caused his death, according to a coroner's report. Scott, you can go.
We're going to switch up. Lex-18 began looking into what happened. The news channel here began looking into what happened months ago and recently obtained documents from a Kentucky Board of Nursing investigation into what happened. The Fayette County Coroner's report states that the man died from, quote, complications of inadvertent administration, NaturaLyte, in the setting of gastrointestinal hemorrhage. The nursing board's investigation into one of the nurses involved in the mix-up describes a series of events that led to the patient being mistakenly given NaturaLyte, a dialysis liquid, instead of a colonoscopy prep called GoLytely. Multiple process failures. Nursing Board Executive Director Kelly Jenkins was limited on what she could say about the specific case, but told the news channel that fatal medication errors are very rare. She said, when you go back and you look at all the steps leading from the time they got the order to give the medication to the time it actually hit the patient, there were process failures, Jenkins said. Multiple process failures. While Lex-18, the news channel, has not seen photographs of the exact medication containers in this incident, available images of jugs of NaturaLyte and GoLytely show similarities. One expert they spoke to questioned why NaturaLyte, which isn't made to be ingested, was available in the ICU. A letter written to the nursing board by the nurse's attorney states that the dialysis team left the dialysis fluid behind on the ICU floor, and it could have been there for up to 3 days. As a safety precaution, nurses have to scan barcodes on patients' wristbands and then scan the medication they're about to administer to ensure the correct patient gets the correct medication in the right dose, Jenkins said. In this case, the dialysis liquid, considered the colonoscopy prep medication, would not scan. The nurse called the hospital pharmacy at about 5:35 p.m. on June 30th, 2022, and informed them that the jug would not scan.
So rather than sending new medication or coming up to see the jug in question, the pharmacy sent a label to the ICU floor through a tube system that is used to send and receive medications and supplies, according to the attorney's letter. A timeline in the nursing board's file says that the label was sent about 5 minutes after the nurse called. The nurse gave the patient about 8 ounces of the NaturaLyte, believed to be GoLytely, before the end of her shift, her attorney wrote in the letter. A timeline in the file notes that the patient was unable to tolerate the liquid. The doctor who had initially ordered the patient to be given colonoscopy prep said that the patient had to take the full amount ordered according to the timeline and attorney's letter. After the first nurse left for the evening, another nurse gave the patient the rest of the liquid through a feeding bag, according to the attorney's letter. According to the timeline, the medication mix-up was caught at about midnight, and the patient died about 7:35 the following morning. The letter from the nurse's attorney to the board also noted that she had been caring for 3 ICU patients at the time of the incident, more patients than she usually would have been caring for as the charge nurse on the shift. The letter states that 3 nurses had been pulled from the ICU that shift to work on another unit. When the patient who ultimately died was transferred to the hospital, she took him on as the 3rd patient.
Oh, you're muted, Bridget.
I think you're muted.
Thanks. Sorry. Like my asthma just started acting up out of nowhere. And I'm just like, so I was taking myself off camera so I could breathe. Anyways, because of the multiple process failures that reportedly happened outside of her role, the nurse in question was not disciplined by the nursing board over what happened. In the letter to the nurse, the nursing board voiced concern that she had not visually double-checked the medication's label before administering it. Medication mix-ups. So the news channel spoke to Ohio State University safety officer Joseph Malucci to learn more about medication mix-ups. And Malucci acknowledged that the complexities of healthcare and the urgency often required can contribute to mistakes. And J. Michael had said how many errors are hidden, though. And I would say how many errors are either like not caught or not realize that they occurred. So I think that this is the tip of the iceberg. That's why technology and fail-safes are in place to help staff slow down and avoid mistakes. Those pauses are intended to be important steps to look at the situation and maybe redo, or perhaps for the first time, do some validation steps that maybe weren't done previously, Malucci said. While technology is used to help prevent mistakes, it can lead to a level of over-reliance and complacency. And I wholeheartedly agree with this. There's nothing like the human mind to evaluate the state of circumstances when you're about to do something that's risky for a patient, Malucci said. Scott.
Those are the things that are taught in our great nursing schools here in the Commonwealth. And you've got to keep to your basics, Jenkins said. Even though you're using technology, because technology, there can be process failures even with the technology. Some assumptions made. In the St. Joseph case, Malucci said it appeared that a workaround was used when the barcode didn't scan. Quote, there were some assumptions made in this case that I considered to be unsafe. I agree. According to the nursing board's investigative file, the nurse involved in the St. Joseph incident attended training on how to avoid medication errors after the incident. She was recognized just 6 weeks later for catching another potentially fatal medication mix-up before that medication ever reached the patient, according to the documents on file. Quote, I hope that many people learn from this mistake and the risks of giving medication and working around barcode scanning, that those risks are heightened and sensitized by this particular event, Malucci told the news channel. I hope your report accomplishes that. CHI St. Joseph Health declined the news channel's request for comment on the situation, saying that instead that it honors the privacy of its patients and does not release information regarding their care and treatment. Additionally, in agreement with the family of the patient you referenced, St. Joseph Health will not disclose or otherwise make comment in response to your request.
And it's in closing, the Kentucky Board of Pharmacy is still investigating the incident.
Is that the whole? I believe that's the whole.
Oh,
yeah, there you go.
Down there.
Okay.
Where to
So
start?
where to start? What are your initial thoughts?
Well, I think reading this and seeing the things that stand out to me and probably due to many nurses are one, 3 patients in ICU and being charge nurse. And so that means that probably I'm just going to venture to guess that all the other nurses had 3 patients instead of 2. And just for folks who aren't nurses in ICU, the accepted standard is a 1-to-1 or 2 nurses per RN, not 3. That is, a different level of care. And usually, unfortunately, in the situation with staffing, this is what happens. So either you refuse to take the patients and you go on some kind of diversion, or you get nurses, or you're going to have to staff your charge nurse. And, this is something that is very, contentious, is about charge nurses having patients, period, because they've got to juggle a lot, especially in ICU. They've got to manage downgrades, be, checking on what the doctors are ordering, upgrades, who's coming in. If this is, I don't know, if they're getting open hearts in this, ICU, they're dealing with OR, ER, discharge, upgrades, codes that are happening. And oh, by the way, the ICU charge nurse usually is the responder of code blues in a hospital. So there's a lot of things that really stand out to me. And I don't think it's also abnormal to have GoLytely just standard. And many hospitals have, especially in ICUs, have, a storage room for dialysis supplies or somewhere. So, again, these are errors that if that was sitting there for 3 days, that's also an issue, and probably about, staffing.
Can you explain to people that maybe don't know what a charge nurse does? Explain to them what a charge nurse does. And then basically when you're ideally, charge nurses should not have patients because they're in charge of the unit. So the fact that this charge nurse had her charge assignment and patients, that just goes to show why staffing is so important. But what are some duties of the charge nurse? Either one of you can answer this.
Sure. So charge nurses, it's in ICU, it's really a lot because, like I said, they have an extra duty that usually nobody else has as charge, and that's to answer codes in the hospital. I believe this is a fairly large hospital. I don't know how big this particular unit is. But the charge nurse has to make the assignment. Patients are coming and going often in ICU, and they could be, there's a lot of transferring and in and out. And so there's changes in assignments. You've got to then manage the skill set of each nurse. And, every nurse is not equal in what their expertise is relative to the disease or the process going on for each patient, what their needs are. They have to go to, usually there's a bed huddle they go to. They're dealing with all the specialists and doctors coming in. They've got to make the assignment for the next shift coming in. And, it's quite complicated, and then they've got to give breaks also. So this is another reason you kind of wonder, well, who was giving breaks, or did these nurses even get breaks? Because, if you take a break, then that means, you've got 5 or 6 patients. That's completely unacceptable if, that nurse is covering breaks also and has patients. So, and then they're also training, as a charge nurse in ICU, this is like an expert level nurse who has got to have eyes on everybody, especially if there's newer nurses in, new hires, travelers. They got to make sure that everybody is doing what they need to be doing. And they do a lot of education in that process. And just going back to the code situation, because that was a situation in my hospital, you could be gone off the floor easily 45 minutes at a time for a code. So then who's watching your patient? So, and it's also, I'm assuming there's no, based on this pharmacy, information, there's no satellite pharmacist situated in that ICU. And this is another thing that we've seen happening, is that pharmacists are being taken away from the floors instead of being on the floors or assigned to units. They're down in the pharmacy, they're short staffed themselves. So again, this is also about staffing nursing and pharmacy.
Yes. And for example, on our floor, just hi, Dad. That's my dad.
Hey, Dad.
So on my floor, charge nurses would have to also round on patients because we have the whole it's like just to ensure that patients are satisfied because of the Medicaid reimbursement. And it's like, did your nurse, it's, you know, all those what it eludes me right now,
The
like
H caps, the
exactly, the H caps. Did your
Mhm.
nurse round on you? Did she explain everything to you? Are you happy? Are you satisfied? So the charge nurse is having to round and check up on everybody. It's just insane to me that, and it's very, it happens all the time now that charge nurses get patients. Like you said, they're out for codes. They are, I mean, they just have so many duties, and they're all also dealing with admissions and discharges, at least on our unit. So if there's someone in the ED that needs to come up to the unit, they're preparing that admission. They're looking to see if they're appropriate for that unit that they're coming to. If there's a patient leaving discharge, then they're looking into who can they bring on the floor because it's that quick turnaround. They're always filling beds. So I can't even imagine having all of that on your plate in the ICU and then having 3 patients. And then so from this article, it sounds like it was the charge nurse that made this error, correct? That's how I'm interpreting it.
Yeah.
And like you said, Nurse Adrian, that's the errors can be made at any time by novice experts. You would think that novices would make more errors than expert nurses, but given the right circumstances, given for example, being overwhelmed, overworked, at that point, anyone can make a mistake, and it becomes more likely every time for each additional patient that a nurse has, especially with higher acuity.
And
J.
this is a
Michaelson.
433 bed hospital, just FYI. So that means I'm going to guess their ICU, unless they have multiple ICUs, is pretty big.
Yeah.
I mean, probably 40 beds. I mean, who knows, but they might have multiple units.
So let's kind of break this process down. And Nurse Scott was nice enough to let me bring this up to compare GoLytely. I'm going to stop sharing real quick. Let me remove this and present. I have to share.
Just wait, everybody. I swear it's worth the wait. No, it points out what we're talking about. And as we talk about errors, and you're like, who could make that mistake? That's a dumb mistake. Some mistakes, not so dumb. Like the names, first of all, of the 2 medications were very similar, like NaturaLyte and GoLytely. So,
okay, so this is what the error that was made. So she was supposed to be giving GoLytely. Let me go here. GoLytely, and she gave NaturaLyte. So the light here, I think, is what messed this nurse up. There's a thing called tall letters or tall man letters where they're supposed to have potential lookalike medications capitalized so that you don't make this mistake. But if each of you want to share how you would have prevented this medication error, they're both clear liquids, but clearly the label is different. So what was your process before you administered a medication to prevent medication errors?
The process to make sure you have the right medication. You read the label. You'll notice that tall boy lettering is actually on the GoLytely. It's GoLytely is in capital. On the NaturaLyte, it's all capitals. That's not tall boy lettering. And also, if I understood this, that was not meant for oral consumption. That should be prominent on the container if that's not an oral solution, if that's to be used in the dialysis machine. Also, I don't know if that was a liquid, but I know GoLytely, because I've had a colonoscopy and I've had to drink that stuff, is a powder, and you have to add water to it and shake it up. It comes as a powder. So like another case that we reviewed, are you grabbing something that you can use right out of the bottle, or is it something you have to reconstitute first? That should also be in the nurse's awareness.
Yes. And if you are a nurse, that you're a charge nurse, that means you've been a nurse for a while. You should know how medications come. Yes, there are changes to medication all the time, but if something looks different than usual, question it. Say, this isn't what I'm normally used to. Why does this look different? And like Nurse Scott said, read the label. So, for example, with me, I am almost OCD when it comes to when I'm working, right? Almost obsessive compulsive, checking everything minimum 3 times. Um, my step is always you're checking the MAR, you're making sure that you're giving it at the right time. Let me present something.
Sometimes they'll
Gigi.
substitute a medication for another. Like GoLytely is a brand name. So if there's another one that's like Light Prep, Lyte Prep, or I'm making that name up, but I mean, if there's another preparation substance, but it's a different company, so they call it something else, I might grab that and say, well, it's ordered GoLytely, but this says Light Prep. I would ask probably another nurse. It's like, is this what we're giving for GoLytely these days? Did they? Or I might even call pharmacy and go, are we substituting this for GoLytely? And of course, one of the points I'm writing down here to myself is, I read this and I'm like, it looks like scanning is so important. And that's something I used to actually not do as consistently as I wish I had. No mistakes were made, thank goodness. But if you scan something and it doesn't scan, stop. Don't do a go around. Don't, I'll give it now and figure it out later. There's a reason that's not scanned. You've got the wrong patient. You've got the wrong drug. Something's going on. And so even if it were a substitute for GoLytely, if it scans, that means maybe that is a substitute. But if it doesn't, I need to not assume that it is and figure that out.
And the MAR should say okay to substitute with, right?
Yeah, the medication
So
administration record for those that don't know.
So, depending on where you go to school, there's going to be 5 or 10 rights of medication administration. But you're checking your MAR for the right time. You're checking it for what medication am I giving. Look up the medication before you give it. What is this for? If you're a new nurse, if you know that I had to give this on my unit, so you get to know the medications. But anytime there's a new medication, look it up, ask questions, be eternally curious. That's how you're going to learn in your profession. So you've looked up the medication, you know what you're giving it. Some of these in-house, they provide you with like a LexiComp. Some of them will have pictures. You can look it up on your phone. What is this drug supposed to look like? After that, I would go to the Pyxis. And at first, before I read this article, I thought maybe, and then you guys can let me know if it's different. So at my facility, it's hard to mix up medication when it comes out of the Pyxis. But when it comes to like saline bags and things of that sort, it would just be like this huge shelving system where the doors would open, but you would still need to pick the right shelf. So that could be a potential for error. So I was wondering, like, I wonder if this was a situation where they selected the wrong shelf. But from what I'm reading, it just sounds like I see the dialysis nurse left this in the room, and maybe the nurse assumed that that was the GoLytely.
Could be.
Is kind of
Could
what
be
I'm
that
gathering.
not everybody has the full Pyxis. The Pyxis is the electronic medication storage and dispensing system, for those that don't know. And for most of the time, you put in your ID and the patient's ID and what drug you want. It opens a drawer and you take the drug out so that everyone knows who gets charged for the drug and this and that. Some of them have those shelves, like you said, with sometimes even supplies. We have crutches and splints in ours, but some hospitals don't have the full system. And there may be some medicines like the contrast that you drink for a CAT scan, maybe just up on a shelf in the cabinet. We just keep it up there. Technically it's a drug, but we don't have space in the Pyxis because it's this big. So it may be, not all drugs are in the medication system.
Right.
And that is only one of many guardrails in this whole system, right? The scanning is one, the Pyxis is another.
And then as I would always bring my computer with me because we had the tough book, as I'm pulling meds, I'm looking at the MAR. I'm looking again, OCD. I'm looking at the MAR. I'm looking at the label. Okay, I'm just going to say lisinopril, right? I'm pulling lisinopril. The Pyxis says I'm pulling lisinopril. I check the label, lisinopril. I check the MAR of the patient, lisinopril. How many milligrams do I need? Whatever it was. And I made sure that everything matched. And there was a situation once where I was pulling, let's say, lisinopril, and they had stuck in like some other medication in there. So because remember that the Pyxis is filled by humans. So humans can make mistakes putting them on the wrong shelf. So you can't rely that all these fail safes, because every so often the stars will align and a medication occurs because like the steps weren't followed.
Yeah,
And
I mean,
that's
we
why
didn't
there are
have.
multiple steps in the system, that because if one fails, the other one should catch it. If two fail, then for sure that third one should catch it. That's why there are multiple.
I mean, I think for me, the red flag just would have been all the writing on the bottle, honestly. And this is really a terrible. You think of GoLytely as a rather benign kind of medication overall. We never had it in our Pyxis, Omnicell, whatever it is. And for those of you not in medical healthcare, it's just like a vending machine, with a lot of stuff in it, a lot of drugs.
Yes.
So, and often, the hospital would change up. Like, so sometimes it would be that GoLytely package that would have then the powder in packets kind of wrapped around or taped on it. And we'd have to empty all the packets in. Sometimes it came with it in there, the powder's in there, and you got to dissolve it. Sometimes then we would just get the packets, some packets that were some generic knockoff that looked like they're from the 99-cent store. And then we'd have to order, call the kitchen or have the house supervisor go down and get Gatorade or something so the patient could tolerate it. So again, I never, it was always something that was manually brought up because of the size. I mean, this is a big bottle, people have to, I don't know, if it's quite a gallon, it's at least 3 liters, I think it would be 6 Gatorade bottles, is what it would amount to. So to make, so that, but again, I'm just not surprised again. And who knows if, it's just also of note, I believe in the article, it says that there's 2 nurses who administered this. So it's not really clear whether the first administration was oral, if this patient had a G tube, a feeding tube, but the second nurse later then gave the rest of it through.
Well, that's
the feeding tube.
Talk about, you get the Gatorade so the patient will tolerate it. That's the thing. The first nurse says the patient wouldn't tolerate it. She gave it to him and he drank it and said, this tastes terrible. That's another thing. It doesn't taste that bad. It's not fun to drink, but it's not,
It's really salty though. It is basically
it's
like
a little
drinking salt.
Yeah. It's not that bad.
But I do agree with Scott in regards to if something is not meant for, in regards to how can we prevent more medication errors, the manufacturer of NaturaLyte should have in big letters, not for PO, or, not PO is oral. So not for oral consumption or something, because I was looking for that and it's not, it's just a lot of tiny little lettering that doesn't specify it.
And maybe the manufacturer is thinking it's a freaking gallon jug. Who's going to think this is for oral, consumption? Guess what? GoLytely is a gallon jug for oral consumption. There are things that are not just little sips of medication. And this is meant to flush out the colon, so you have to, over a period of time, drink this whole amount.
This is what the label looks like. I was able to pull it up just because. But it just says it's a liquid acid concentrate. So the poor guy, I mean, he already has a GI bleed, and this acid only exacerbated the situation. But I did see here, again, I understand it doesn't have it in big letters, but it says that wear safety glasses, gloves, and clothing suitable to prevent when handling. Acid concentration can irritate eyes and skin. So if you see that it's a skin irritant, it kind of makes sense that, maybe I shouldn't be putting this in my mouth, right? Like,
well, there
that should
it
be
is
a red
right
flag.
there under requirements for use only with a 3-stream hemodialysis machine calibrated to blah, blah, blah. You had it right there, requirements. For use only with this machine.
That's a lot of.
But I still
small little lettering.
I still feel like in bold they should be like, not for oral consumption.
Should be right around the top of the jug, just like those medications that say caution, paralyzing agent.
Exactly.
Same thing. As you go to unscrew it, you should be able to not miss it.
Exactly. And this is a concentrate. This is diluted with bicarb. So it's, and also just for folks who aren't nurses listening or watching, this is something that is typically not digested in it can go over into another shift. It's not something somebody's just going to chug and finish. It's one of the very few medications I can even think of where the patient's not going to finish it maybe in your shift. It has to be finished by midnight or a certain time period, and it could take several hours for the patient to ingest all of it, depending on you know, I mean, I've had patients vomit after it, you know, one sip, and you know, it can take a while to get in. So it's not uncommon you're going to leave it for the next shift for that patient to finish, or, you know, however, because and you cannot put that much in a G tube. Like that's also something, a feeding tube, you could not ever put that large a quantity
Well,
at
it
one
would take
time.
some time. Yeah, it would take
Yeah.
some time. Like there's large syringes you could fill up and put in, and then fill up and put in, and fill up and put in. I mean, it would take some time to put a lot of volume into it.
So
But the way it goes, the way, if I remember, you had like an 8-ounce glass, and then 15 minutes later, another 8-ounce glass, and then 15 minutes, then that's about the time you start, and you're like, okay, I guess it's working. And I was ready for a
Mhm.
night from hell because I had been told all about the terrible, you know, diarrhea and the cramping. And it's like I went, I had a diarrhea, and I came and I drank some more, and finally I was having, it comes out clear. You're
clear.
like, okay, I'm done, and it stops because you stop drinking it and you're empty. And I'm like, it wasn't that bad. I just watched TV, and every couple of minutes I had to get up, go to the bathroom, but it didn't ruin my night. It didn't, you know, but it is maybe, you know, 8 ounces at a time you could put in, and then come back in a few minutes and do it at 8 ounces more. But yeah,
I'm just curious what the settlement's going to be, because Kentucky actually has a history of some pretty high settlements,
mm,
and if things go to a jury. So I'm guessing there's going to be a large settlement on this case. And it is very sad because clearly this patient, you know, suffered.
yeah.
And with this kind of liquid in the GI tract, I mean, it's just so unfortunate on so many levels, but it speaks to the issue of staffing, the, you know, the issue of pharmacists. Pharmacy oversight is just a huge, even having a pharmacy tech assigned to the floors would be great. You know,
Hmm.
somebody who is managing the drugs, because there's a lot. And here's the thing, in ICU setting, there can be a lot of medications kind of just laying around and being brought in and dropped off, you know, whether physically dropped off or tube, like this would be too big to tube, you know, in the tube system. But, you know, so there can be a lot. And this is why it's important to have appropriate staffing, and, you know, have secretaries that are answering the phone, can deal with bringing visitors in, answering questions, you know, all those things. You know, it's just very unfortunate. And I think this is another reason why, you know, ICU nurses are also kind of saying, hey, you know, this stress is a lot. You know, I know a lot of ICU nurses who are stepping down. They're saying, hey, you know, med surge rehab's not too bad, tele's not too bad. You know, I'll adapt, because the risks involved and the responsibilities that you have as ICU charge. And in many places, you're just not allowed to refuse to do charge. And that's another issue, you know. And I'm doubting this is a union facility, but, you know, charges kind of can be forced on people whether they like it or not. And there's, you know, it can be very difficult to say, I don't want to do charge. But, you know, in California, you know, we would teach nurses, hey, if you are taking patients, you immediately say, I'm no longer charged. You notify the house supervisor, you shoot a little email off, I'm done being charged for this shift. Find somebody else not doing it.
That's why it's important to advocate for our profession, to have join organizations, protest, do what it takes to help with appropriate staffing. I did want to say that the dialysis nurse, I do feel like the dialysis nurse is also to blame, because you just don't leave stuff or hanging around, right? I've had patients that have dialysis, and at our hospital system, there's a contracting company that comes from the outside that does dialysis. And yeah, they bring huge jugs. They ask for IV bags all the time, but they clean up, they leave. They don't just leave their stuff behind. And
But then was there a policy not to do that? Because to me, I'm not defending it, obviously, but in
mhm.
the moment, you're thinking, well, I got to come back tomorrow and do the same thing. I'm not going to drag this whole thing, this gallon jug out of here and then back. I just put it, there's a spot on the cabinet over there. It's clearly labeled. It's not like, you know,
Well,
mystery.
we don't know if
But
it was labeled, right? Okay, so
well, there's a lot we don't
unless it was unopened, maybe if it was, but remember, like if we open a some saline or whatever, we're supposed to label it, date it.
know.
Um, I guess as an extra precaution, that is a good point, Scott. If they had, let's say, you know, dialysis Monday, Wednesday, Friday, and she's coming back, then write on it with a Sharpie for dialysis use only, right? Be extra cautious because you are essentially leaving a medication there. It's not like you're just leaving Gatorade or something hanging around. This is something, and clearly it was dangerous enough that it caused patient harm.
Yeah, well, let me play devil's advocate. In
Mhm.
hindsight, that is absolutely clear, and everything you said makes perfect sense. Before this all happened, it didn't seem like a big idea to just put a jug of my clearly labeled dialysis solution up on a shelf. We're assuming that's what happened. In hindsight, we're like, wait, someone could make a mistake with that. It's dangerous. In the moment, though, they're like, I'm coming back tomorrow. You can understand why that nurse, you wouldn't blame that nurse for not for having left that behind in the med room in a corner someplace, unopened to be used tomorrow or the next time they come through. But now, of course, we realize it's a big deal. I wanted to make the point. You guys all realize we're asking people in the ICU especially to do the impossible. We're asking people, human beings like you and me, to keep another person who is critically ill, whose body is currently falling apart, to keep them alive using all kinds of technology, including pharmaceuticals and monitoring equipment and all of this. And not make any mistakes, never to make any mistakes. That's impossible. How do we make the impossible happen? We don't have just one person do it. And we set up all of these safety nets around that person so that it's not just them remembering everything. We've got resources. You can look things up. It's not just them giving a medication at the right time because they remembered, oh, it's time to give medication. We have a medication administration record. It's not just them picking the right medication. They have to scan it and the patient. We have all of these things that we've talked about so far so that if there's a mistake in one area, it gets picked up somewhere else. And that's why these things don't happen as often as they do. They do still happen because in the end, you're asking people to do the impossible, really.
And there have been situations where this is slightly different, but sometimes your brain will see what you want it to see. And sometimes I'll explain it by you are proofreading your essay and you're not reading it out loud. You're just reading it. You don't spot a written mistake, like something is misspelled, but you're just looking at it and you don't see it. But when you read it out loud, you notice, oh, I misspelled this word. Let's say dialysis, and you spelled it with a SES at the end. But when your brain will correct it sometimes. So pausing, if that barcode did not scan, instead of calling pharmacy 2, you can ask a colleague, hey, I'm supposed to give GoLytely and it's not scanning. Can you take a look at this for me? Am I giving the right medication? Get an extra pair of eyes because sometimes you're tired, your brain's not working right, you're overworked. Have someone else double check it for you. That's the whole purpose of why we always ask another nurse here. And again, every state is different, but insulin, before we give insulin, we have, hey, this is this many units of insulin. Is that what, or I don't even, can you check my insulin? How many units do you see? It's better you don't tell them because then their mind will see what they want to see. So how many units of insulin do you see in this syringe? And then they'll tell you, okay, perfect. That's what I'm supposed to give. So double check if something's not scanning, double check. They said here, and that goes to what Nurse Adrienne was saying about, I've never had a pharmacist on, like just a pharmacist for the floor. Yeah, that would be nice. I've never had that, but we just had like a farm, the central pharmacy for the whole hospital. But it said here that the pharmacist didn't come, but instead sent the label up. And I mean, honestly, that's probably, I've never seen a pharmacist come to double check something. I mean, is that something that is normal? Because that's never happened on my unit.
I've worked a couple of ERs where we've had a dedicated pharmacist in the ER. It's larger
Mhm.
hospitals. And if there's a problem, you can just say, hey, I got a question about this medicine. Like, yeah, oh, they're so happy to get up from their desk because they're just doing med recs all day long. And they're just like, you need help at the bedside? They're ready to go. They're like, okay, let's go
Mhm.
take a look at this. And they're like, yep, this is what this is. You know what this is? They changed the label on this. They changed the formulation. Let me call the doctor. We'll get the order changed. They're like using their expertise. They love that stuff.
Normally what was
But
happening at my hospital, they wouldn't, I don't know, they just didn't like to leave their little station. I would go to the pharmacy. So they're always like secure, like locked. And I'd be the one like, hey, can you let me in for a minute? And then I'd be, I'd go with whatever I needed to ask.
yeah.
But that's another option. If they don't come to you, you can go to them.
But again, you're abandoning your patient in the ICU that needs one-on-one care.
Yeah, true.
There's all these competing, if I leave, I'm in trouble, but if I say I'm in trouble, if
Yeah,
I
you
ask
can't
for
win.
help, I look weak. If I don't ask for help, I could make a mistake. And who was the guy Malucci, the guy or the gal Malucci that was quoted in here, because something that person said jumped out at me.
It was a
Acknowledging,
Joseph Malucci, but what did he say?
but he said something about urgency. That mistakes in the hospital happen, and something about urgency. So we can do
Yeah,
Control F, urgency maybe, but that's the thing. Urgency is urgency. There are times when things need to go quickly. Here we go. The complexities of healthcare and the urgency often required can contribute to mistakes. True. If you have more than one patient, you have more to do at one time. That creates urgency. So if you have fewer patients, that will decrease that. And also, this, once again, folks, is getting ready for a diagnostic procedure. I'm not going to name the name of the other case that we've talked way too much about in the last year or so, but that was also in preparation for a PET scan. This was in preparation for, I think, a CAT scan.
a colonoscopy for GoLytely.
Or colonoscopy, which in this case, the patient is bleeding, but it's not, if it were emergent, they would have just gone in there and done something, so it's urgent, but it's not emergent. So there was time to check and double check and ask for other people to look at the labels and things like that. So there's urgency that can't be avoided. And there's urgency that can be avoided, but because of the circumstances, you're just understaffed. So now there's more urgency because I got all kinds of stuff to do. And then there's not really urgency, but we call it urgency. Like, we got to get this done. Do we really? Are you sure you can't wait another hour until I get this double checked? Are you, so I just wanted
And
to
there's
point out
nothing,
that word gets thrown around in a couple different ways.
and because the way GoLytely is given, I mean, it's not a life-saving medication that is urgent. And we know it's going to be given over time. I wanted to bring up a couple just thoughts that I've, looking at this. One, the age of this patient, right? 81 is actually a very high risk for a colonoscopy. So, that's also a consideration. Um, you know, Sometimes we're scoping patients quite a bit. And of course, that is the only way to find out and cauterize, what might be a bleed. But I'm curious to just know what the rest of the clinical presentation of this patient was. But also, pharmacy, again, pharmacies are running like they're, running the 100-meter race also. And there's something that was missed by them is that they never sent the GoLytely. So they didn't have let's just think back. Upon review, it should say whether that medication was dispensed.
Exactly.
Sent. Oh, oh yeah, I know the tech. We sent this again. It's a big hospital, 433 beds. But I'm really curious how many pharmacists they have on staff. If they come back, because I'd like to see what the pharmacy board comes with. If they come back and they've got like 3 pharmacists on staff on duty, then yeah, that's a disaster, right? That many beds, you need about 10 pharmacists on. So, that's another stopgap where in their system, they can see, was that medication dispensed? Did they produce a label for it or not? And then where is it? And that's where when the pharmacy staff correctly, they could ask the techs who do the delivery. Usually the techs will be the ones delivering medications and restocking the Pez dispenser. They will be, hey, did you deliver this to the floor? No, I didn't. Okay. Because, this is something that was probably ordered, everything's like stat in the ICU. So that's another area that was overlooked that I'm just guessing the pharmacy's just running crazy busy too.
And they probably didn't check because what you say, GoLytely is seen as such a benign medication. It's so run of the mill that it just didn't seem worthy to check, not worthy, but it's not a life-saving medication. We'll put it that way. So they were probably like, I'll send up a label.
And things change all the time. So even if they notice, hey, nobody pulled that out of the Pyxis, that GoLytely, or we didn't deliver the GoLytely and nobody called us to say it was missing, things change. It's like, well, they probably delayed the exam. The patient maybe started to crump and they're not ready to, and they decided not to give it. So the fact that it wasn't pulled or delivered may not be a huge
What if they were so busy, right? What another thing is that could have happened is that maybe the pharmacist was so busy that they didn't even check to see. I think that's what, Adrian, is that what you're saying? That maybe they didn't even check to see if it was dispensed. Like when they got the phone call, they didn't even say, Oh, let me check in our system. Oh, we show that you never pulled this medication. So what
Right.
are you
Well,
what do
you
you
don't
have in
send
your
a label.
hands right now?
You don't
Right.
send a label. You don't send a
Right.
label.
Well, and that's
That's like my
because
patient doesn't have an ID band, so you go and you get a label from the secretary, and then you scan it. And no, you
yeah.
make a new band, and then you check with the patient to make sure you're putting it on the right patient, and then you scan it. You don't just grab labels and
And
scan things.
GoLytely, just so folks also know who may not be familiar with this process, is that most medications that are in they're individually wrapped, they're in the dispenser. Hey, Mr. Midwife, they do scan that barcode that's directly on the manufacturer or the packaging. Some things like GoLytely don't scan, and so they have to have a patient pharmacy label that is assigned that medication to that patient. So so that usually is brought up, has a label on it. Again, there's all different systems, so I don't know, what the system that they're using is. Ours, for example, never scanned, so we would always have to have they'd always have to bring it up with a label, or they, somehow if it was multiple packages, it's like
Yeah, like if, for example, like it's an inhaler, they'd have to print their own, they'd have to
right,
make their own label for that patient. It would be
exactly.
in a Ziploc bag and the inhaler would be inside, and then there would be a label on the outside of the Ziploc bag so that you could scan it.
I thought
Right,
all
because the
products had
inhaler's in a
pre.
box, so you have to take it out of the box, then put that label on the
Mhm.
inhaler. Right.
Oh yeah,
Well,
not
I'm
the
talking
first
about
time you
scanning
do
for
that.
the MAR, not like it's a different, yeah, the inhaler, but again, it depends on the system. And Olivia said that it's, I do see mistakes. However, it's so easy to find fault in these postmortems after something awful happens. And yes, of course, like that saying, hindsight is 2020. But thank God that's why we do these so that we can learn from them. I'm not doing these live so that we can bash other nurses, but again, you almost do have to be OCD because we are honestly, it's like we're set up for failure by our hospital administration. And it's very sad, but we're set up for failure. So we have to take it upon ourselves because at the end of the day, we're the ones that are held responsible, not the hospital, unfortunately. So we have to have, that's why we're discussing, Nurse Adrian, what do you do? Nurse Scott, what do you do? I'm sharing what I used to do. And to my knowledge, right? Because I'm not perfect, but to my knowledge, I had never administered a wrong medication to a patient or, too much or too little because of all these steps that were in place. Were there situations where I could have potentially? Yeah, but I caught them because again, I was checking as I'm pulling from the Pyxis, or I went to pharmacy, or I did, what needed to be done. And I'm not blaming them. I know life gets busy. I know things get hard. But at the end of the day, these are human beings and they are suffering. It happened to my grandma in Colombia. I've shared this with you guys before. My grandma went in for an MRI. She had anxiety and she died. She was completely fine before, and they either gave her the wrong medication or too much, and she died in the MRI. So patients should go in the hospital and feel safe and should go there to get better, not for us to essentially, clock them out.
Well,
And
and
this is
most
oh,
of
go
them
ahead.
do. Most of them do. Something you said I wanted to mention is you talk about OCD, 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 and I think that sounds like it's a condition, like somebody is either OCD or they're not OCD. I don't think you need to be OCD to be a good nurse. I think you need to develop good habits,
Okay, I
which
like
look
that.
which are probably close to OCD. But checking the label and checking the label and checking the label, that can come from the fact that you're
Mhm.
OCD, but it can also come from the fact that you've just developed really good habits. So I've said this, and I have given medication in error, and I openly admit that nobody was hurt, and I won't go into details. But one of the things I did, and this um, is always check the label. Like I'll draw it up and like, okay, we're gonna give you some of this, and I'll scan them and scan this, and always like draw it up and like, okay, and I want to give, and I'll look at the label. Just a habit I got into, and none of my mistakes were because I drew up the wrong medicine and gave it. They were for other reasons. But that's just one of those little things. I'm not OCD. I just got into that good habit of doing it. And so new
Mhm.
nurses or old, even experienced nurses, get into some new good habits if you're worried about something like this.
And yeah, I will retract. I like what you said better, Nurse Scott, because out of respect for people that have OCD, like um it's almost like disrespectful to mention that because OCD is its own condition and it can be very debilitating. So I do like that better and I will adopt that is adopt good habits, and
You can even say OCD-like habits.
I was fortunate to have excellent instructors that they were and here's the thing, when you're in nursing school, it has to be hard. It's hard for a reason. I'm sorry, but it has to. I'm no longer teaching, but I see so many and there's a difference between the instructors or the professors that are just rude and mean. I'm not talking about that, but I'm talking about those that hold you to a high standard, because again, we don't want something like this to happen to you. It's the difference between like a parent that spoils the child or a parent that disciplines the child because they want what's best and they want that child to grow up with good habits. So if your instructors are tough on you, it's because they're trying to make you a better nurse and prevent this from happening. Olivia said, yes, for sure. I live in constant fear I will make a mistake like this. And I don't think, maybe we do, but personally, I don't think we discuss the mental toll that being a nurse takes on us, because when I first started nursing, I would have nightmares. I would have nightmares that, my nightmares would be so realistic. It was like I was right back on the floor, and I somehow I would wake up thinking like I never went into a patient's room. I don't know if you guys ever had nightmares like that.
Yeah.
Like, oh my gosh, I had a seventh patient and I never knew. Or
only
yes.
waitressing and being a nurse. Those are the only two jobs I've ever had that I had nightmares, and they were almost identical.
That's true. I think I've actually had that. You're just like, oh my God, I've had this patient the whole time and I haven't even looked at them. It's the end of my shift. I have to give a report. I think I've totally had that dream.
Yeah. Yeah. Like you just realize, oh my God, I had that patient. What? Yeah. And I think it is good habits. And, I mean, I don't know. I kind of think, well, if nursing school is not like boot camp, then,
Yeah,
you
but your
gotta
nursing school was like boot camp.
you got to question it. But it's, it's the nature of where we're at in healthcare. I mean, I remember being on tele, right? I was a tele nurse and did step down. So I always had 4 patients or 3. We never, ever went over ratio. Just want to say,
That helps
and
so much.
very rarely did the charge ever have patients. And actually, we would protest if we came in and the charge had patients. We would refuse to take breaks. We would not allow that nurse to cover our patients because it's not safe. Because if I, again, just aside, if I allow somebody who's already got 3 patients, 4 patients to take my patients, I'm complicit in anything that could happen that could go wrong during that time period in California. So but I want to say that, on this issue you're running around, I remember having, all 4 of my patients on potassium riders. So, 4 potassium, 2, a couple bags of mag. And then you're like, why are we even doing this when the oral form is much more effective? But, you're running around just carrying, and we would have generic. So they were just generic bags that would come out of the dispenser, whichever one, Omnicell, whatever one it was. And, so what are you going to do? You're going to grab, it's like, you're on an assembly line dropping bags off because you're just running around, because by the time you finish one round of giving bags, then you've got to do med pass, then you've got to check blood sugars, then you've got to bathe patients, you've got to chart, and then you've got to go back around an hour later and give all these patients riders again. And it would just be insane, sometimes it would be 6 bags. And these are very dangerous medications, by the way. But in the absence of having like a little extra help or having kind of a balanced patient load, you're just running on like vapors, basically, when you have a patient load like that. When I hear of nurses having 6 patients, or having these really high acute patients on a med surge and, they're on vents or something, we have to hold the standards. We are the patient advocates. I mean, I'm a private patient advocate. This is exactly why you have to hire a private patient advocate, because you got to have somebody in there who's at the bedside or who's reviewing things and what's going on. Although in this case, probably wouldn't have made a difference because you're not really going to be at the bedside 24/7 unless you hire somebody to be there. But in ICU, it's a little different. But again, this is why you kind of have somebody who's, eyes on the situation, because most critical care patients are not fully conscious. They're heavily medicated. Even if they are conscious, they're not really, with it. Like, people do not remember anything when they're in the hospital, period. Because usually they're medicated. Doctors come at 3 a.m. You get ICU psychosis. That's another factor. so who knows what, is going on with this patient, but this is just a really horrible, horrible error that happened. And we have to be diligent in taking our time, because it will be a medication error that is probably, I'm going to say, the most likely reason that of all the things that could happen to a patient or that you could miss, right? That's the most trackable. That's the most traceable. If you miss a wound dressing, right, that's not really traceable, whether you charted it or not, or didn't do it the right way, or maybe you didn't have the right medication. Those things are often just at the bedside. So again, I'm a real advocate for having, wound care nurses, having more pharmacists, it's not just nurses, it's having all the staff that we need to take care of patients. And this is something that the public really has to get behind. You got to get behind ratios.
Everybody's overworked at the hospital. Respiratory therapists, pharmacists, everybody's running on fumes. And that's why nobody wants to go out of their way to help anybody else. I'm not saying there are, we do help each other out, but usually it's like, I'm sorry, I'm too busy, or, I can't go up to the unit because I have to do this. I got to go to the ER. Like, that's the problem. If we all were properly staffed and had time to just breathe, then a lot of these situations would not be happening. But I mean, as nurses, I think we have tried and tried, but the public has to get outraged. The public has to get outraged to not blame the nurse, not blame the individual, but blame the hospital system. They keep constructing new floors, new units, but yet we are overstaffed. I'm not we're understaffed all the time.
Well, and that's one thing I was going to say. I got the reputation on the other panel discussions for always seeing the bright side of things. And I told myself this time I'm not going to try to be so Pollyanna about everything. I'm going to try to, see
no,
things
I like that. I like that about you, though.
Here's what I want to say. This is a case where everything went right. And hear me out. The mistake was made, yes. But that first nurse, there was many things that were done right, especially after the fact. That is not the case in a lot of other cases. So the mistake was made. And the nurse said, my patient doesn't like drinking this and it's not scanning. So what did she do? She called the pharmacy. That was the right thing to do. Okay. Now the pharmacy sent up the label. That was the wrong thing to do. Or she used it to scan. That was the wrong thing to do. And then we passed along to the next nurse. So she kind of, I wouldn't blame her much, because she did the right thing pretty much up until, except scanning that label. The next nurse then gave the medication, even though the patient couldn't tolerate it.
But wouldn't the next nurse have also needed to scan the medication? Or do you think that the first nurse just scanned it? Well, maybe what happened is GoLytely is only on the MAR as a one-time med. So once that first nurse scanned it, it grazed it out.
Right.
So, but that nurse should have, and this is why, again, be weary of, look at the bottle, say, what are you giving? Because she passed that on to the other nurse.
Not have had to scan it. You're right. Well, then, so afterwards, here's what happened. Somebody caught it, right? They tried to do something with the patient, because it was several hours before that patient died. So they caught it. The patient didn't die immediately. So they were obviously doing something to reverse this. It didn't work. And unfortunately, sadly, the patient died. Then afterwards, they didn't try to hide the whole thing. It was reported. The State Board of Nursing looked into it, because there are nurses involved. And did they throw that nurse under the bus? No, they said, you know what? This was one of those situations where the nurse made a mistake, the pharmacist made a mistake, the system wasn't set up right, the labeling was bad. It was the Swiss cheese model that everyone's heard of. When all the holes and all the slices of Swiss cheese line up, that's when the mistake gets through. And then they didn't try to throw the nurse under the bus. They didn't throw the hospital under the bus necessarily. The hospital didn't try to throw the nurse under the bus. They didn't try to make excuses, except saying that healthcare is complex and there's often a sense of urgency, which they're not wrong. And this news channel, in reporting it, seems very factual and didn't try to make anyone out to be the villain. And we've seen in other cases where the hospital has tried to hide the mistake, where the nursing board has thrown that nurse under the bus, even though it may not have been entirely that nurse's fault. And we've also seen situations where, unfortunately, in my opinion, and I had a minority opinion, that there have been cases where it was the nurse's fault, that there was one nurse who missed several of these times to pick up on the mistake and didn't. The rest of the hospital was working as it should. And in that case, it was the nurse's fault. We could just debate that elsewhere. But I thought in this case, no one got thrown under the bus. It was well reported. It wasn't hidden So the mistake was bad, but what happened next is about as good as you could expect under the circumstances.
Yes. I mean, because of, Radon I feel for nurses. Like, I'm like, okay, part of me is like, yet. They haven't charged her yet. They haven't penalized her yet. And I hope that they don't. But it's one of those situations that really set a really dangerous precedent for nurses, that they can come after us personally, our licenses, based on a medication error. I hope because she attempted, but I mean, it's almost very similar. It again, a scanning error, just like VOT, very similar. Olivia says, and yes, Olivia said that they wouldn't have to scan again, just trust the nurse before you. How do you guys feel about that?
Yeah, you don't trust patients, you don't
Well,
trust nurses.
with GoLytely, I mean, it's like, like I said, sometimes we would do it in Gatorade bottles. So then you've got all these packets of like emergency kind of stuff. So they're all laying there, and it wasn't like one packet went to one bottle. And so it was like one packet was two bottles, so
And
sometimes the
it's
patients would say, hey, just line them all up, just line up cups for me, and I'll just boom, 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 right? So again, GoLytely is a really specific medication that there's no way to scan. There's always a ton of it left over, usually for the next shift. And there's no way to double check what is, the patient could have bourbon in that container. Who knows? Right. So there's no way to really check it. But then you don't want to like just leave the bottle there. Like, so usually sometimes we would actually mix the bottle and then we'd put a basin with ice, on in the sink. So so it would be cold for the patient and as they're drinking it, because again, nobody's drinking GoLytely in like an hour, right?
no,
And
they're
not a
not.
gallon. So it's just one of those things. And then sometimes you scan it, and it's just literally the only drug I can think of where you're not watching the patient take the full dose. Oftentimes, because here's what will happen: you scan it, okay, great, here, take a sip. Oh, the patient's going down now for dialysis and they're leaving the floor. They're not coming back for 6 hours, or they're going down for a scan. It's now the next shift. There's just so many factors with GoLytely specifically that, it is, but this is like the perfect storm where there just happened to be a bottle of something else. It's a very similar kind of looking gallon container that just happens to be a caustic detergent for
But
the dialysis.
because this medication is administered in this way, and this happened this time, I mean, it can happen again, essentially. Like, that's what's concerning, because
Yeah.
you're right.
That's why we talk about it here. That's why they've written an article. So hopefully some changes will be made. And
I don't know what the solution is on GoLytely, because this would be an issue sometimes, I would say, in the hospital, because, I'm signing off that the patient took the medication, then the patient doesn't finish it. They just do 1 cup out of 8 or something. Now the GI doctor's mad. They're writing me up because I gave the med at 2 p.m. The GI, scope was 8 in the morning the next day, but the night shift nurse, whatever, didn't put a note in that the patient refused to finish it. So what I will say for nurses, here's an idea. For nurses, here's a tip. If you're administering GoLytely, create a note, an actual nursing note, not a note in the medication. Make a nursing note saying exactly how you're administering it to the patient, what the directions are to the patient about it, taking it, what the patient's response is. And if you have to leave on your shift and there's still some left, you should make a nursing note about approximately how much is left for the patient to ingest, and that you have given report on that to the oncoming nurse, and also reminded the patient and put it on the whiteboard, even though we hate whiteboards, right? If that's appropriate.
So,
in our hospital, I have to say something you mentioned about pouring it in cups and leaving it there. We used to use gastrographin, and it was a multi-use, and we would do so many ounces of gastrographin in water or some apple juice or whatever. And the orange stickers that we would put on the IV bags when we add medication, like if you add potassium or whatever, and you stick it on there, we would always write on there and stick it on the cup, on the styrofoam cup at the bedside. So it was always labeled the way we did it, but of course, different places do it.
and see, I was day shift. So yes, I've had to leave GoLytely, but I never thought about that. Night shift comes in and they really just are trusting us. But I think what we could do is day shift could leave the packets there, whatever, for the nurse. Say, look, this is what I have poured in this. this is GoLytely, and then what Nurse Adrian said or Nurse Scott, label it, right? I was a big fan. Anything I would label everything, normal
Yeah.
saline, whatever, everything. When you opened it, where just so label the cups or put a label on something, whatever jug you're using, and leave the packets there so night shift can see. And you can let them know, like, hey, if you want to throw this away, feel free to, but I wanted to leave this here for you so you could see what I put into this container, just to show that you did everything correctly. And then if you're night shift coming in, just, I mean, tell them, listen, there was a situation where a nurse gave the wrong medication, that patient died. So sorry, but going forward, can you please leave the bottle so that I know what you put in here, or leave the packet so I know what you put in here?
You should be between your charting and talking to the patient and what's on the whiteboard and labeling your medications and labeling your cups and everything, you should be able to drop dead, and someone could be able to come right in after you and pick up where you left off. They wouldn't have to go, I wonder how long this IV has been running. It's in the chart. I wonder if that patient's already been to CAT scan. Have you been to CAT scan? You did. Okay, they know. I wonder what's in this styrofoam cup. It's labeled on the cup. At any
Everything you
moment,
do.
everything has to be ready for you to just vaporize into thin air and someone else to come behind you and pick up after you.
One of my teachers always said, chart with a jury in mind. So, for
Yes.
example, let's say that a patient is declining and you are trying to call the doctor. They're not calling you back. You say, first call placed at this and this time. Let's see. Olivia said, my facility is big on bedside shift report safety checks. The labels could be part of that. Seems like it would be tough to execute across the board, though. So,
No,
anyways,
it's
chart
not.
chart chart with a jury in mind. At this and this time, first call placed to physician, did not answer, left voicemail with answering staff. Second call placed at this time, did not answer, voicemail left. Went to charge nurse, blah blah blah. So chart everything. If you are doing interventions for a patient because you have a gut feeling, like Olivia said, CYA, right? Cover your own behind so that you're and if you are ever, again, chart with a jury in mind, so that if you're ever called in court, the jury can see everything, and you're saying, look, I did this, I did this, I did this, I called a rapid response, whatever, that you did everything in your power to help this patient.
But be very careful about using other people's names. I think charge nurses, they get their names put in there. Charge nurse Susie or charge nurse David, notified that the doctor hasn't called us back. But I made the mistake one time of like, I need to go down to one patient. I have two patients to give away, so I could be one-on-one. That's how we do things in the ER. And I charted something like nurse so-and-so refused to take the patient, and then nurse so-and-so refused to take the patient. And it's like, oh, you can't put that in the chart. I'm like, you're right. I'm sorry.
And again,
I was trying to cover my ass, but at the same time, I was implicating somebody else, and that unnecessarily. So yes,
what I've charted, Scott, is
but not. I just don't put a lot of names in charts.
I've charted insufficient staff to meet patient needs and able to give report.
No, I wanted to be sure that someone knew that I tried to give the patient and they refused me, and I wanted to make sure that they knew that I wasn't failing to give my patient up. Someone actually refused me. I want them to know who, but in that case, that was inappropriate. There are better ways to do that, so don't do that. But when it comes to I notify my charge nurse that they can look up who was on duty that night, but I think it's okay to put the name because they know that as being a charge nurse, you're going to be taking reports like that. So
you always want to chart as objective as possible and avoid saying like patient was mad or frustrated, or I love using quotes. If a patient is cursing you out, quote it, quotes, instead of, and just be as objective as possible while not throwing people under the bus, but also protecting yourself. I'm going to wrap up here. We've been on for about an hour now. Any last thoughts that you guys have?
Yes, because the name was brought up. It's very rare that a nurse is completely responsible for an error. It can happen. In most cases, it's like this, where it's like Adrian said, it's the perfect storm, right? Everything just aligns and it happens. What we do afterwards, I think, is important. We talk about it. We don't blame. We try to learn from it. We try to institute policy change. Someone said, I don't think that's, we could do that across the board, doing handoff shift and labeling. You absolutely could. How bad do you want it? And I think at the next level up is a message I try to get across with some of those other videos, that this can scare a lot of nurses out of nursing. It can scare people from coming into nursing. I think it's our job as people dedicated to the profession to say, Yeah, it's scary because it's a really hard job and we have, but a lot of responsibility. But we accept that responsibility. It can be done. People do it every day. And especially if we support each other and try to keep making improvements like this and not throwing people under the bus. And we need to keep reassuring the public when they see things like this that we are responsive to these things that happen, that we are continually committed to doing the impossible to the best of our abilities, because we've been number one on the most trusted profession among the public for years and years and years. Let's not lose that because we start this infighting and pointing fingers and also scaring people away. We're going to be short staffed as long as we keep scaring people away. So don't scare
Yeah,
people away.
but I feel like we're also short staffed. I
Right.
feel like there's availability of nurses. They just don't want to work in those conditions.
Well,
It's just that's a whole
create
other
better
issue.
environments. Like Nurse Liz says, there's not a nursing shortage. There's a shortage of nurses willing to work under those conditions.
Right.
So
Because
improve the conditions. Don't scare people away. Improve conditions. Don't throw people under the bus. Let's come together so we have more people working, all pointed in the right direction to help patients out.
yeah, I think I have 2 points. One is this is a charge nurse with 3 patients. I'm assuming everybody else had 3 patients also. And, charge nurses have to leave the floor, take everybody else's patients down to MRI, CT, or cover patients. So it's a miracle that other mistakes didn't happen with all the patients, honestly.
Yes.
And this is a very dangerous situation. It's Medicare fraud because the hospital is billing for services based on a 2-to-1 ratio. So I want to point that out also. It's Medicare fraud. Patients, all patients need to start asking their nurses, how many patients do you have? And they should know what the normal standards are. And in ICU,
Yeah, here in Florida, sorry to cut you off, but here in Florida, it's awful. I mean, the norm is 3 in the ICU sometimes.
It's becoming the norm, right? But patients have the power, right? The CMS right now is really cracking down. There's, there are some good things happening with Center for Medicaid systems, but patients need to ask and they need to go up the chain of command and demand that they have a nurse who is appropriately staffed, who is not overloaded, stretched thin with 2 more, 3 more, 1 more patient than they should have of a standard ratio. And look at the California ratios if you want to know what the standard should be. So this is something patients need to take responsibility for. I don't know, where this patient came from, but
Kentucky.
Again, if you're the family, be the advocate and start asking, because the patients and the public are the ones who need to rattle the tree.
Yes.
Because that's where the change is going to come. Please, please advocate for ratios, everybody, in every state. And this hospital is going to settle. I can guarantee you, unless there's no family and this patient was in a SNF and had nobody, they're going to settle for multiple millions of dollars, because the juries in Kentucky have awarded up to like $8 million in patient deaths for something even less than this. So all that money that is spent in settlements can go to staffing, can go to nurses, can go to training. It could go to pharmacy techs, more CNAs, right? More techs.
Exactly.
So,
You save more money by avoiding lawsuits and by avoiding nurses quitting and by not paying travel nurses a bajillion dollars. I'm just, it's a hyperbole,
It's a
but
round figure. It's a round figure.
it makes sense, doesn't it? I'm like, it's like these administrators have no common sense sometimes.
right.
I want to just piggyback quickly on what I agree and I disagree with you, Adrian. It shouldn't be the patient's responsibility to do any of this. You should walk into a hospital and just be honest about what you're feeling and what's going on with you and let the healthcare system take care of you. Unfortunately, the more you know, Adrian's right, the more you ask questions, the more you advocate for yourself and your loved ones, the better off you will be. Ideally, though, it shouldn't be. But
it seems like they will listen more to their patients than the nurses. And that's why she's saying that, because unfortunately.
I know exactly. I'm just saying, though, it's a sad state of affairs when we put the burden on the patient to do this, when they're the sick one. They're the ones with the cancer they're worrying about dying from, But you're right. The more the patient and the family is involved, that will help improve the system and care for that patient as well.
All right. Well, thank you so much for watching. Make sure that you tune in next time we go live. We don't have a set time, so just check our channels for updates. Thank you, everyone. Make sure you like, subscribe.
Thanks, everybody.